Good afternoon, everyone. My name is Stacy Thompson, and I'm the Senior Director of Events Strategy here at Business Publications Corporation. Thank you for being here today for our second Fearless Focus of the year. When we launched Fearless about 5 years ago, our vision was clear: to create a space for meaningful conversations and connections through open dialogue, shared experiences, and peer-to-peer learning. We believe that for women to thrive and succeed in work and in life, we need a supportive community committed to lifting one another up. Today, as we gather for this important conversation on women's health disparities, we also recognize that it's Juneteenth, a day that commemorates the end of slavery in the United States, and it calls for us to reflect on equity, justice, and freedom. It's a powerful reminder of why spaces like Fearless matter, because progress depends on courageous conversations and on creating room for everyone and every voice and experience. Fearless is proud to be a part of that journey, and through our content and through our events like today's webinar. In today's discussion, our panelists will focus on disparities in women's healthcare, and the data paints a sobering picture. Women, especially women of color, continue to face significant gaps in care, research, and access. Our panel will explore not only the challenges, but also the emerging trends in women's healthcare here in Iowa. Most importantly, the real solutions being put into action to create a more equitable future for all women. Shortly, I will turn it over to our moderator and special projects editor, Emily Wood. But before we begin, let's take a moment to thank today's sponsor, On With Life, whose support is making today's events possible. Serving thousands of people each year, On With Life is a world-class neurorehabilitation facility dedicated to helping individuals recover from brain injuries, strokes, concussions, Parkinson's disease, spinal cord injuries, and other neurological conditions. They provide care focused on the unique and complex needs of brain injury survivors. Here to talk a little bit more about On With Life is their Public Relations and Marketing Director, Sarah Basowski. Sarah?
Thank you. So as you can see, I'm not our CEO, Jean. She unfortunately was a little under the weather today, so you get the understudy. But I'm very, very happy to be here and to be part of this amazing panel. It's something that is very near and dear to our hearts. I think, as Stacy mentioned, we are a neuro rehab facility. Our main location is in Ankeny, Iowa, and that's where we began, and that's where we have our inpatient program. So people who are coming right out of the hospital, who have had some kind of neurological event and don't have anywhere to go and are not ready to go home. So that's where they start. And then we have, kind of our continuum of care, which includes, post-acute inpatient, outpatient. We have a beautiful new outpatient building on our Ankeny campus now where, often people who are in our inpatient, program move to. We also have a brand new long-term skilled care program in Polk City, which we're very proud of. That is something that, was kind of an unexpected move for us. We were in Glenwood, Iowa, and that facility was a state-run facility and was closing down. So we then had to kind of pivot and moved our wonderful person served, 2 almost 3 hours from Western Iowa to Polk City. And that's been a wonderful change for us. We have residential neuro rehabilitation and independent living. So we have apartments for people as well. We also have neuropsych and counseling. And then most recently, we partnered with the New Horizons Center in Ankeny. So we now have day services and respite services. So that's a little bit about On With Life. We were started by families who were in this situation and didn't have anywhere to go. And we have continued to be, very focused on helping persons served basically get home. That's our mission.
It's fantastic. You guys are doing great work, and the rate at which you're growing is contributed to that success. So we appreciate you making today possible, and for the services and programming you guys provide for the community. So thanks for joining us.
Absolutely.
And on that note, I will turn over to Emily Wood to dive more into today's conversation and to introduce our panelists.
Great, thank you, Stacy. Healthcare has been one of the most pressing topics that we've covered since launching Fearless. Our health, of course, greatly affects how we show up in both work and life, and that's why it's important for us to discuss the challenges in receiving adequate care. While there's been significant progress since the days of the widespread belief that women were too feeble or too weak to work outside the home, medical research still often doesn't prioritize women's bodies and the conditions that predominantly affect women. Some research has found that women's health concerns are often not taken as seriously. For instance, one 2022 study found that women who visited emergency departments with chest pain waited 29% longer than men to be evaluated for possible heart attacks. Women of color face even greater health disparities compared to white women. That's why we found it important today to talk about some of the health challenges facing Iowa women and some of the solutions that are out there. From mental health to oncology to maternal health care, there's no shortage of topics for us to discuss today. Before we start, I want to acknowledge that even though there are collective healthcare issues facing women, health is a very personal and often complex subject. Our goal, of course, is to have a fact-based and respectful discussion. And audience members, we want you to be a part of it, so you're welcome to offer thoughts and ask questions in the chat at any time. We've got a great group of experts here to talk with us today. With us, we have Dr. Wanaki Carr, an OBGYN with the Iowa Clinic. We have Tara Geddes, Chief Nursing Officer at Floyd Valley Healthcare. Nicole Knighty, Assistant Professor in the Department of Epidemiology at the University of Iowa College of Public Health. And Christina Shark, Executive Director of the Southern Iowa Mental Health Center. So I've asked each of our speakers to start off by telling us about a healthcare challenge facing Iowa women right now that you're focused on addressing. So Dr. Carr, let's start with you.
Hi, as Emily said, I'm Dr. Carr with the Iowa Clinic. I practice general obstetrics and gynecology. I've been in practice here in Iowa for about 7 years now. I practiced in the Quad Cities before I came back to Des Moines about 3 years ago. One thing that we struggle with as a state is just having enough obstetrician gynecologists to take care of the large patient population that we have. We are, I think, last right now in the United States for the number of OBGYNs per capita for birthing women in this country, which is pretty sad. We're losing a lot of birthing centers. A lot of hospitals are closing down due to lack of funding. And so a lot of OB units are therefore closing down in rural communities, therefore causing funneling of obstetric care in the more metro areas such as Iowa City, Des Moines, sometimes the Council Bluffs, Waterloo, and the Quad Cities. So I think right now, one of our most biggest health challenges in the state is just having enough doctors to care for all the women who need care and increasingly complex care as women, unfortunately, are becoming sicker and have more comorbidities during pregnancy. And also, you know, in the spirit of Juneteenth, and like Emily stated, like Black maternal morbidity mortality is very high comparatively. We're higher than the national rate as well in the state of Iowa, where right now Iowa, I think, is about 6 times more likely for a Black woman to die in childbirth compared to a white woman. The national right now is about 3 to 4 times. So that's a huge thing that we need to address in our community as well to take care of women.
Thank you. Tara?
Hi, I'm Tara Geddes. I'm the Chief Nursing Officer at Floyd Valley Healthcare up in Lamars, Iowa, in Northwest Iowa. I think one of the biggest challenges that we're seeing for women's healthcare is purely access to healthcare in general. So as Dr. Carr mentioned, over 40 maternal centers in Iowa have closed over the last couple decades. That's a huge number in our state. And so that leaves women having to travel further, not just for maternal care, but even specialty care. For example, in my area, it is not unusual if you need to see a specialist to have to travel to Omaha or Des Moines. Maybe if you're lucky, Sioux Falls or Council Bluffs, but a lot of people are traveling very far to get healthcare, which then women put off because they don't want to leave. They can't leave work. They have family priorities and things that are coming up. And so it's very difficult for them to get the care that they need. And we just have definitely some access issues in our rural areas.
Thank you. Nicole?
Hello, I'm Nicole Knighty, Assistant Professor at the University of Iowa, and I lead the Empower Project, which is a patient-centered collaborative of over 20 women who use drugs during pregnancy. So my work is informed by their lived experiences. And so, similar to the other panelists, I also believe in Iowa, one of our most pressing and overlooked health challenges for women is access to care, particularly access to substance use treatment during the time of pregnancy. So, we know pregnancy can be this really critical window for change, but only if we have a system that's there, that's ready to meet women when they're interested in receiving care. Sadly, our system often falls short, also in the state of Iowa. So, in a recent study, my team called every licensed substance use treatment center in the state of Iowa. And when we called these centers, nearly half of them never answered the phone. So, imagine if you called 911 and nobody picked up half the time. And that's the reality a lot of Iowans are facing today. So even when someone does answer, though, the path to care is often complicated by long wait times, lack of childcare, insurance barriers, and stigma. And this can lead many to engage from care. And so that is one of the biggest challenges that I think about in Iowa and hope to address in my work.
Yeah. And Christina.
Yeah, I would agree with everything that the panelists have said so far, but I would also add just another kind of unique spin to it when it comes to women in particular. I think one of the biggest barriers to women getting the mental health help that they need is there still definitely is an era of stigma surrounding mental health. I think especially for women, we are the caretakers for everybody in our family and usually in our family systems. I know in my own life, I'm the one that makes sure even the dog gets to where they need to be. So if we're the ones that are feeling weak or feeling sad or depressed, sometimes there's just not time in the day for women to take care of themselves because they're the ones who are so busy scheduling everybody else. We're usually the ones who, most women are working full time. Most women are not staying home with their children and their spouses the way maybe we saw years ago. And so when we have full-time jobs and we have full-time responsibilities and we are just the keeper of all of the things, it makes it really hard to take care of ourselves and make ourselves a priority. So I honestly see that as one of our big stigmas for mental health treatment is we just don't prioritize ourselves the way that we need to.
Thank you. Well, you've all shared very important topics that I hope we can dig into today. I want to start by digging into maternal health care. And as a number of you mentioned, that Iowa currently ranks last among the 50 states with the fewest OBGYNs per capita. So I was just curious, Tara, from your view in rural Iowa, what is that meaning right now and what's going on at your hospital in particular?
Sure. So in rural healthcare, a lot of times we can't afford to hire OBGYNs. We don't have the volume or the finances to be able to do that. So our family practice doctors will do the OB care for our patients here. Of course, that means they do low risk patients. Anything that's a higher risk is going to be referred on. But that does mean that many of those patients then are traveling, if we're lucky, 30 to 45 minutes just to get OB care. That doesn't mean that those high-risk patients aren't showing up though in our ERs, just because we don't have high-risk OB physicians here. So we still have to make sure staff are also prepared. Our nursing staff, our ER physicians are ready to prepare to those emergencies that come up that we don't see on a regular basis. So we're trying to make sure that all of our employees are trained on that. We work with University of Iowa and their simulation labs to come to on-site to get some training for those things that we don't thankfully see very often, but need to be ready to respond to.
And another factor in this, of course, is that in 2024, the state implemented one of the most restrictive abortion bans in the country. Dr. Carr, I wonder, are you seeing if those restrictions are affecting your patients at all, or do you see any future effects that might have?
Yeah, I see it twofold, one from a patient perspective and one from a recruitment perspective of getting doctors to come to the state. So on a patient side of things, we have a lot of patients who are worried if they do have a pregnancy complication, what will that mean if they desire a termination or if they have pre-viable PPROM or where their water breaks, but the baby is still in the early second trimester and won't survive. What does that look like? Do they need, if they're not infected or not Do they need to go to another state to have a termination? Especially when this was first rolling out, a lot of patients were very concerned. On the other hand, too, we see a lot of patients who haven't had children who are now asking to get tubal sterilization procedures done because they don't want to have an abortion, but they also don't want to be in a space where if that is something that they desire or that is needed, that they can't have access to that. We have patients who are concerned to tell us their last menstrual period to get a pregnancy test because they are concerned that later on that may be tracked or it may be held against them if for some reason they have a termination out of state or have take medication to end a pregnancy. From a recruitment standpoint, if you're someone who plan to provide abortion care, you're not going to want to come to Iowa to practice. You're going to choose another state. You're going to choose some, if you're from the Midwest, you may choose someplace more friendly, such as Minnesota or Illinois to practice where you know that you can provide that care if it's needed. We've had patients who have had to go to Minnesota or to Kansas City or other areas to get terminations for fetal anomalies that may not be non-lethal, but would have significant effects on if the child was born. And so patients have to make those decisions. The physicians have to decide if they feel comfortable coming to practice here. So we know that if you're from here, you're a higher likelihood to come back here. But if you're not from Iowa, what's going to have you come into the state to help practice? So if this state isn't friendly to practicing medicine without politics involved, people are going to be less likely to come.
Nicole, what other maternal health care issues are you currently seeing in your research?
Yeah, I mean, I wanted to piggyback a little bit on what Dr. Carr's comment is related to recruitment. Another part of it is student and trainee recruitment. And so that's something that we think a lot about in graduate and medical education programs. And so oftentimes, really great providers aren't from here, but if we can get trainees to come here to our training programs, then we can hopefully be more likely to keep them here in the state of Iowa. But if our training programs are not able to provide educational experiences for all aspects of maternal care, it's going to be really hard for us to get those really good trainees into our state and then to later stay.
And Christina, when it comes to mental health care as it relates to either those who are pregnant or maybe moms in general, what are some of the challenges that you're seeing folks come in with?
Yeah, we definitely see moms or young mothers or pregnant women. All of those types of things are welcome in our center. We will treat anybody that has any kind of mental health symptoms, regardless of some of those demographics. But certainly that's something we can kind of tailor our treatment plan around a little bit carefully. Sometimes we do run into issues with our prescribers. If we have a patient who presents to us on certain types of medications, particularly like some injectable medications or some antipsychotic injections, our prescribers won't keep those things going once the woman does become pregnant without some consultation time from the university. Just our close proximity from Atomo to the University of Iowa, we work with the Women's Health Clinic there pretty closely, and they're usually pretty good about just walking through our prescribers, you know, like, yes, this one is safe. No, you really need to pause this one for the duration of the pregnancy. So that is one issue. Sometimes our psychiatrists, we have 2 psychiatrists, and they don't always feel trained adequately to be able to deal with medications as it relates to a woman who's expecting. But then certainly after delivery, they can kind of get back on track with the treatment plan they had before they were pregnant. So we do try to work through those things, but without that kind of partnership at the university, I don't think we'd be able to treat those patients very well at all. So I would say that is one piece we really need to think about. And then as far as our therapy is concerned, we do have quite a few therapy modalities that address attachment issues. That's kind of a separate conversation, but sometimes women with mental health disorders have trouble attaching or bonding with their new babies or their children or their newborn. And so we do have therapists that specifically specialize in that kind of bonding and attachment issues. That's so critical in those first couple of days of life, really. But all throughout that first year, really, we try to really emphasize just their own trauma situations, the way they were raised with their parents, the way they bonded with their parents doesn't need to be the same story, and how that bonding and attachment is really, really critical right after delivery. So that's something that our therapist will really try to focus on for that specific demographic of women.
Thank you. Dr. Carr, did you have something you wanted to add?
Yes, we see a lot of times when patients show up for their first OB visit that they will have stopped all of their psych medicines. And they're like, I feel horrible, you know, and I say, okay, let's go through what you're taking. We need to make sure that you're back on this, this, and this, and this. Because 90% of the time, what patients are on is actually safe in pregnancy. So we see that a lot, that either their primary care doctor or they just like out of concern for how it would affect their pregnancy, they stop their medications and have some mental health relapses. So that's just a huge thing that like we just need education about in general, that like we know that pregnancies have better outcomes when mental health is better. So
And speaking of the shortage with OBGYNs across the state, I'm wondering, Tara, you all recently had an expansion of your birthing unit, and I'm wondering if you could talk a little bit about that, how that was able to come to fruition amidst a lot of closures happening around the state.
Sure. So we really recognize that there were a lot of closures in neighboring counties to us. And so we were at a point, we were losing some of our volume in OB, which when you start losing volume, it's hard to recruit physicians and be able to keep those competencies and skills and be able to do that in a safe manner. It's also hard to recruit the nursing staff into that. And so we had to make some choices. And are we going to have to close our unit down, or are we going to grow our unit? Because staying the same was not going to be an option. And it was without a doubt, we needed to buckle down, we needed to grow our volume, and we needed to grow our unit. And so we did polls in our community, to our staff, our providers, about what are moms and families really wanting to see in the maternal space. And so while a lot of places were closing, our volumes were also going down. We decided we're going to grow. And so we took on a full expansion of our OB maternal units. We relocated that to a different area of our hospital. We more than doubled the size of our rooms. Our rooms before were great at the time when they were built, but with modern technology, family needs changing, they just really got small and cramped. And that was really a dissatisfier for families. We recognized that it was not a care issue. They were really happy with the physicians. They were happy with the one-on-one care our nursing team gave them. It was more the aesthetics of the space and the space. And so when we did that, we opened that in November of this past year, and we're already seeing a significant increase in OB volume just with changing the aesthetics of it. We have the same staff, we have the same qualified physicians, just being able to really meet what our families were needing, and it's been great for our community.
Mm-hmm. I'm wondering too if there's also part of the challenge, it can be at times that as some of the smaller communities have had to transfer other health services, or as you had mentioned, with people having to see, you know, an expert elsewhere, that they feel like they just should take their care elsewhere, even though there may still be care available in their community. Have you had to do a lot of communication around making sure people in the community are aware that the care there still exists and is strong?
Right. Well, I think in general, there's lots of studies that are out there that show if you can kind of affect the entire life cycle for women, they're more likely to stay there for everything. So women make the choices primarily in households. So a lot of times moms are choosing what doctor our whole family's going to go to. So if we can get them early through the maternal care that they have, as those babies come into the family, those moms are making choices to stay here for not just maternal care, but the entire healthcare for their family and themselves. And we're keeping that local so they don't have to travel to get that.
Dr. Carvey mentioned that the maternal mortality rate is much higher in the state for women of color, and especially Black women. I'm wondering what you're seeing in terms of some of the solutions that are being practiced right now to try and combat that.
I think over the last couple, I'd say like 5 to 7 years, this has become more in the mainstream. So I think both patients and physicians alike are a little bit more conscious about systemic racism, explicit bias, and how that can affect how you care for patients, whether it be because they're Black or Latino or Indigenous or they have a lower socioeconomic status, and trying to make sure that you're providing quality care for everyone who walks through your doors, regardless of their situation. So I do think that is more on the minds of individuals. Same thing with taking steps to reduce the number of cesarean deliveries, which can lead to more complications. So I'm trying to make sure that we're not doing unnecessary C-sections, that for the first C-section, if it's needed, that it's indicated. So I think those are some steps that like we're seeing kind of in the physician world. We're seeing more patients get doulas, especially more Black and brown patients have doulas to help them. For those of you guys who are not familiar with what a doula is, they are essentially someone who is a support for someone during their pregnancy, during their labor and delivery, and in their postpartum course, to help empower women to ask questions at their visits, to make birth plans if that's something that they desire, help them through their laboring space so that they can feel empowered during that delivery process, or have an extra support if they don't have someone who can be that support system for them, and also help them in the postpartum state. Sometimes they can help them recognize postpartum depression or signs of preeclampsia, or help them with breastfeeding, and that can help reduce anxiety. So those are some of the things that I think in the birthing community that we're trying to work on to help reduce maternal morbidity and mortality. Also, from a legislative standpoint, working on increasing the access to Medicaid and insurance, because if you don't have insurance, you're less likely to seek care. And we know that Black and brown patients are disproportionately affected, higher rates of Medicaid use. And actually, people don't realize 40% of birthing women in the state use Medicaid. So increasing the access to care, we have lengthened, or the state did lengthen Medicaid for 1 year postpartum, but unfortunately they also increased the threshold for someone to qualify in terms of like, so we're maybe lengthening for those who still qualify, but less women are now going to be able to have access to Medicaid. So that's something that we need to continue to work on to help make sure that folks have access to care, that they feel empowered to ask questions, to speak up if they're not feeling right, to help kind of help reduce that increase.
Mhm. Nicole, in your research on substance abuse and pregnancy, what are you seeing as some of the barriers for folks that you've talked with in getting the care that they need?
Yeah, so I think it's both a policy issue as well as within the care environment. So one is when you ask women what their biggest barrier to care is, they'll tell you how they're treated. And so they specifically will talk about stigma. A recent study that our team did is we found that women who reported stigma and discrimination during their prenatal care and their substance use treatment during pregnancy were 2 to 3 times more likely to disengage from their substance use treatment. So that would be things like methadone and buprenorphine, and also 2 to 3 times more likely to return to use and overdose in the first 6 months postpartum. And so the way that we treat patients really does matter. The other part is policy. And so, in many states are not friendly towards women who use drugs during pregnancy. So, in the state of Iowa, something that I've learned from talking to patients here is if there is indication of substance use during pregnancy and that they're reported to the Department of Health and Human Services, these women will go on a child abuse registry for at least 5 years. And so, there's a particular person that I work with. She had a baby 4 years ago. She hasn't used any substances since that baby was born, and she still remains on that child abuse registry, which has huge consequences related to if somebody will rent a house to her, if somebody will hire her, and things like that. So we have a lot of policy to work to do in the state of Iowa.
Yeah. Well, thank you all for talking about the various factors around mental health or maternal health care. I want to turn to talking about workforce within healthcare right now. And I'm wondering at the various spheres that you all are in, I know there was a lot of talk, especially during the pandemic, with burnout challenges. And I'm wondering, what is the current status of the workforce that you're seeing right now at your organizations? So maybe Christina, starting with you.
Yeah. In mental health, this is something we've always struggled with. It is a difficult field to work in for a lot of different reasons. But I do feel like as far as the pandemic dip that we saw, we are starting to come back from that. We don't have as many openings as we used to have. And I also feel like this is one area where maybe our state has done a little bit better job of kind of expanding the qualifications and the type of personnel that can work in the mental health field. So when I first started in mental health back in 2001, it really was just like that. Licensed therapists did the bulk of the treatment and the bulk of the work. And I do think in the last 20 years or so, we've gotten a lot more creative about the way we can use different types of staff and different types of people with different types of education. For example, we now employ quite a few community-based case managers, people who go to the person's house. We have community mobile crisis staff, somebody who can go out into the community or go out to the person's house if they're in a crisis. And in both of those situations, it doesn't require a licensed therapist, which is a very kind of high level degree and high level license to have. But in both cases, sometimes we get really almost the same results as you would if a person did see a therapist. They feel supported, they feel less escalated, their crisis seems to resolve when somebody will come to them. And so I do think we've gotten a lot more creative about expanding who in the mental health space can do the work, which in the end, the result that we're looking for is symptoms decrease. So if a patient's able to get their symptoms to decrease, from a visit from a community worker that will come to their home and meet with them in their living room in a place where they feel more comfortable, then that objective has still been met. Now, obviously, for some things like medications and those kinds of things, we're still reliant on prescribers because that takes a completely different skill set. But for someone who's experiencing like a mental health crisis, for example, we are able to get a lot more creative in how we meet those needs without having to have them come to the center and see a therapist, which is really the only option we had for people, maybe 20 years ago. So in some respects, I don't want to jinx us, but I do feel like in the mental health space, this is getting a little bit better because we've broadened our scope of how we treat mental health and looked beyond just that therapy patient relationship and gotten a little bit more creative with more home-based services, which have had really good results.
And when you mentioned the community crisis response, have you seen results in helping to reduce, the involvement of law enforcement or the criminalization essentially of mental health issues?
Yeah, 100%. And I didn't really even speak to the fact of how good this kind of delivery works for women, because actually in Iowa, and we are not perfect. You guys have pointed out really, really good policy things at the state that still need to change. But in Iowa, we have enacted a mobile crisis team that now covers all 99 counties. So to dispatch the mobile crisis team, anyone can dial 988, which is the nationwide emergency hotline number. But in Iowa, that is how you reach the mobile crisis provider for your county. So if you don't remember who's the mobile crisis provider for Story County, you don't have to know who that is. All you have to know is that you can dial 988 to get a hold of that team. And so what has happened is, especially women who feel like they can't leave because they're the caretakers, they're the ones taking care of their children. A lot of times we see single women at home. They cannot come to our crisis unit, at 8 o'clock at night because they've got children to get to bed. So this has really helped with some of those barriers for women, especially who feel like, they just can't leave their families, and they don't have to do that now that we have this team that will come to them. And then, yes, absolutely. Your original question I sidetracked about law enforcement is has panned out as well, because a lot of times people will call 911 because they're not aware of 988. We know that if we call 911, somebody's going to respond to us when we need help. That's just kind of a learned public education type of message that we've gotten out. And it's a great message if your house is on fire or if you're having a heart attack. We want people to use that system. We want to support that system. But in a mental health crisis now in Iowa, we have another option. So we're hoping that the more people reach out to 988 and have a good response, because the reason 911 works is because people show up if you dial the number. So if you dial 988, you still have to have people that respond and have a good response, that then becomes kind of the public education message is, if your house is on fire, if you're being robbed, if you're having a heart attack, there's still 911 available. But if you need mobile crisis to come to your home because you're feeling very escalated, you're feeling suicidal, you're feeling, in some type of mental health crisis, use this as an alternative to getting the police involved. And we're hoping eventually, and we have seen some effects of that. People aren't using 911 as their first go-to for mental health related issues. They're veering more over towards 988. But I think in time, as people have good results by calling that number, that public health education message will continue to spread, that there are alternatives. If you need a mental health crisis care, you don't have to go to the emergency room and you don't have to call your police department. There's some alternatives that are in many times just as effective, if not
Right.
better, really.
Thank you.
Mhm.
Dr. Carr, what does the healthcare workforce look like for you? How have you seen it shift over the past few years?
I think what we've seen is that it's harder to recruit, especially if someone's not from the state. Um, I think even, and this is more anecdotal, you can correct me if I'm wrong, that applications and people applying to like the University of Iowa for residency have probably gone down a little bit over the last few years, especially since the pandemic and since the abortion legislation has come through. Um, I think if you're in the metro, you're having an easier time recruit than if you in the metro as in Des Moines or in Iowa City, you're having an easier time recruit than like Waterloo or the Quad Cities or Clinton, Iowa. Because it's hard to be say, oh, guess what? We don't have any OBGYNs left in our community, but let's have you come fresh out of residency and be the only one. That's very intimidating. So that's a huge problem right now, is recruiting out into more rural areas, especially if someone's coming fresh out of a training program. The other thing that though, what is hard is when you have the more private practices, the more smaller practices, they're really struggling for revenue. So it's hard for them to bring on a new physician as well. So that's another thing that people are in the state are struggling with in terms of recruitment, and then even just retention, honestly, that people have decided to leave the state in some of the more rural areas because they are burnt out, because they're caring for so many patients that they can't keep going at that rate. So they choose to leave the state or move to a more metro area where they have more support, where they're taking less call, where they don't have to see an overwhelming number of patients a day. Um, what we're doing is like a lot of the practices in Des Moines, I know, kind of like what Iowa City and the University of Iowa does, is we have rural communities that we do shared care models, because they can't keep midwives on staff, or their L&D is closed, or they don't have family medicine OBs or high enough OB staff to care for patients. So they'll see them early pregnancy and then have them come up to Des Moines for shared care models. So just because it's just been so hard to recruit.
And I'm guessing too that I think in general patients like to go to someone who can relate to them, and oftentimes someone who looks like them. I'm sure in particular with your patient load and knowing the statistics around disparities, that you're seeing more patients of color that want to come and see you specifically. Are you having to turn folks away at times?
For gynecologic care, I'm not necessarily, nobody's getting turned away, but the wait times are quite long. Yes, I tell patients, if they want to continue to see me on a regular basis, or they're trying to establish care with me, to call about 6 months out. That's a long time to wait for an annual exam. That's a long time to get established with a physician. For a general OBGYN too, I'm not even a specialist. So that's kind of what the wait times are. And across the metro, just to get in for an annual exam is probably about 3 to 4 months for an annual, probably at this point.
Tara, what are you seeing in Lamar's in terms of impact on workforce, and how and how things are going right now?
So we're seeing a lot of what Christina mentioned, Dr. Carr, as well. There are certain specialties and certain professions that we aren't having as much difficulty recruiting, and others that we're having pretty drastic difficulties with. I think nursing and physician side of things are probably our biggest challenge as far as recruitment goes. It's really difficult to recruit. We've got an aging workforce, so it's really difficult to recruit new grads. There's not as many fun things to do in the rural. I mean, there's a lot of great things, but when you're fresh out of college, it's not always the most appealing thing to go into a rural space. And so, as Dr. Carr mentioned, a lot of them do kind of go to those metro areas where a lot of their friends are kind of working at too. And it's not to say that they don't also have recruitment issues there, but it really is hurting some of those rural areas that it's just, we can't compete with that. We also can't compete from a wage perspective either in those rural areas, and that's with all of the different disciplines that we have. We are experiencing some of that. On the flip side, I would say though too, we are also seeing more people going that have the interest in nursing, people that left nursing, particularly during COVID and the pandemic. Some of them are returning into nursing now, which is really great to see. We're also seeing a little bit of shift in our workforce where I've been a nurse for about 25 years. And so when I started nursing, it was like really the kind of gold standard was eventually get into a clinic and have that Monday through Friday position. We're seeing a shift right now in that where a lot of our staff are looking for more of that work-life balance. And so they recognize doing those 3 12-hour shifts and having 4 days off a week is almost more appealing. So ironically, we're seeing a shift from what we saw 20 years ago where people were really wanting those clinic jobs that now they're really more into the hospital side of things. But also we do have some of that burnout on that bedside nursing too. It's a very physically and mentally demanding job for our providers and our nursing staff and all the support positions that go with that. We're seeing an increase in our mental health needs that are coming through our ER. The violence towards workforce has increased, not just in the state of Iowa, but nationally. And it's something that we are definitely seeing locally as well. And so we as an employer have to respond differently to what our really to keep our patients safe, our employees safe, and try to give them what they need so they don't get that burnout. And we're doing the best that we can there by looking at mental health it's probably our next big focus that we're working on, and having some specific mental health spaces that are safe. So if we have someone that's coming in a crisis that we don't have to worry about taking all the furniture out of the room. We have safe furniture that's in the room, making sure that they can't harm themselves or harm anybody else. And so we have to do that to protect our workforce and to protect our patients.
Nicole, anything you would add about what you're seeing with workforce right now?
Yeah, and so I think what I hear from patients is they oftentimes will go to a maternal health care provider who doesn't quite understand substance use or what medications that are safe to be able to use during pregnancy, or they'll go to a substance use treatment provider and they don't know a lot about OB care. And so really they struggle in trying to figure out where to go. And so I think we need better training for our workforce. I hear from a lot of patients, providers will tell them it's not safe to take methadone or buprenorphine during pregnancy, which is not true. It is the gold standard of care for that population. And then in the postpartum period, they will get a lot of misinformation related to safety and breastfeeding. And so in terms of workforce, what I hear from patients is we just need better training to support those patients.
Tara, I know something you've mentioned before too is that the healthcare workforce is predominantly women, but that's not necessarily the case in healthcare leadership. And so I was wondering if you might just talk about that a little bit too and what you're seeing there.
Yeah, I think it's important, regardless if it's gender, ethnicity, that we have some diversity in all levels of healthcare. It's just critical. As you mentioned before, patients want to see providers that look and act like they do. And it's the same from a leadership as an employee. You want leaders that you can resonate with and connect with. And so I'm very fortunate the organization I work with, we are 50-50 from a leadership perspective. And it really is a good reflection of what our workforce is. But sometimes if you get into those larger organizations, you can see a lot of that senior leadership level is primarily male driven, which isn't necessarily bad, but it is good to have that female perspective on there too, because we do bring a different family perspective into that too, and we can offer more from that side of things.
Right. Well, thanks for the thoughts on workforce. I'm sure we'll continue to talk about that, but I want to make sure we get to a variety of different topics too. So Christina, I know you've mentioned some, of course, but what mental health issues are you seeing that are specifically affecting women, and what are some of the barriers for providing them care?
I don't don't know that. I guess I would say specifically for women, I mean, when we look at different diagnoses or different symptoms, they certainly experience all of the same kinds of things as a man would. I mean, we definitely have women who are feeling depressed and anxious, that type of thing. But I would say one thing that's unique to women is just kind of the comment I started out with was just this overwhelming feeling of stress for being, just the keepers of so much stuff in their families and in their home and in their work. A lot of our women are working full time now. We know that women are juggling jobs and they're juggling kids and they're juggling a lot of care that needs done around the house. So maybe some anxiety is just more common. Another barrier we see with women is so many times I think a woman will delay getting any kind of mental health help that maybe she needs because too often we kind of excuse some of those symptoms for just a hormonal thing. We think, I know even sometimes myself, I'm guilty of thinking to myself, is this, temporary? Is this going to pass? Or is this a symptom that I really need to have looked at? So I think men don't have that factor in their lives. They can't blame their thoughts or feelings or symptoms on their hormones the same way that women are kind of taught to. That's almost something that's kind of just kind of taught, kind of ingrained in us since we're young women to think about, well, you have like different hormone issues. So sometimes we see that as being an excuse or a delay for treatment. And when in reality, we want everybody to reach out and get some help when they need it. So I would just say, yeah, just kind of that overall feeling of being the caretaker, I think is just a really hard, unique factor for women in their homes.
Dr. Carr, related to the topic on the hormonal fluctuations that women face, of course, whether it be menstrual cycles or menopause, it seems to me that I'm seeing a lot more conversations, which is a good thing, of people talking about how that affects especially work life and in life in general. But I'm curious to know if you were to recommend something to employers in terms of how they can be inclusive to women, knowing that they have the different physical aspects. Is there anything that you think employers should be doing?
What in terms of like menopause and perimenopause?
Yeah, menopause, or even just, I know in I don't know that I've heard of anything in the US, but I know in other countries I've heard of even some things around menstrual cycles too that employers will acknowledge.
Yeah, I think it's important. Like I've had patients who said, I'm going to get penalized for getting up to go change my pad because I have heavy periods. So I have heard that from patients a lot where I was like, but they're going to let you bleed out, like bleed at work and not allow you to have proper hygiene. So I've had to write notes for patients so that they can like get off their like a telemarketer, get off their call or get out their seat to go to the restroom. Like it's just crazy to me as adults that we need to ask permission to go to the restroom. Just saying. But that is some things that I've seen, or patients who have dysmenorrhea or painful menses that are really struggling with that, um, and just need like a little bit of a break or something at work, or need some time to sit down. I feel like if for my perimenopausal women who are going through hot flashes or are going through really irregular bleeding patterns, I think it's just like be mindful as an employer that if you're going through this, like you'd probably want somebody to empathize or sympathize with you. I have the same thing on the pregnancy side where I have patients who have like significant nausea or vomiting, or they have a pregnancy complication that means they need to reduce their workload. We ask for reasonable accommodations. We don't say everybody has to be on bed rest, but we ask for reasonable accommodations, and we see that women are getting fired for what I would think for many instances or something that we'll resolve in a week or two, or we'll resolve after the pregnancy ends. So I think just like from an employer standpoint, from an HR standpoint, like being mindful and like allowing for reasonable accommodations, like someone to go to the restroom to change their menstrual product, or making menstrual products more available in the workspace, or so that people aren't worried that if they have their menses starts, they don't have products on them, that they have to leave work or change, things like that, or just allow it. Like to me, it's just common sense. Just allowing for this. If you're going to have women in your workplace, help them be more efficient with their job by allowing for some of these basic accommodations to be made. So,
And shifting gears here again, but I know there's been some recent studies that have come out, and this isn't just for women, but in general, that the cancer rates in Iowa are very high right now. And Tara, I know you in earlier in your career worked in oncology, and I'm just curious what you're seeing in that area and how that's affecting women in Iowa.
Yeah, we are definitely seeing increased number of cancer cases. I can just speak anecdotally with our organization as a whole and community area. You're starting to see, I think it feels like a lot more younger people coming in, especially with colorectal cancer. It's just people that necessarily wouldn't reach that screening level. So they're not doing those routine mammograms or colorectal screens in their 20s and early 30s, because that's not right now the indicated age of that. And yet we're seeing an increased number of cancer diagnoses in this age group. With that brings on, you're treating somebody in their 20s and 30s very differently with cancer in some ways. Socially than you are going to for a 70-year-old. Like, they may have little kids at home still. They may get a diagnosis in the middle of a pregnancy and you're trying to navigate that. And so those are some challenges that we're seeing, and it really need to be ahead of that in education to our the healthcare workforce, that these are symptoms regardless of age that you might see, and that we don't get so tunnel vision that think that 20-year-olds and 30-year-olds don't get this types of cancer.
And Nicole, I know we've talked throughout this that there's a lot of the research in the medical arena is not always focused on women. I'm curious, what do you think we need to do to change that? And what are some of the solutions out there to get more research based on things that affect women?
I wish I knew the answer to that, especially as a researcher who relies on funding for the work that I do. And so it would be to support research on women, which unfortunately right now feels like that's going away a little bit, but just recognizing that it is important. Women experience things differently than men. Historically, our clinical trials mostly included men. And so the medications that are for men and women may not work as well for women because they weren't tested and done with women. So I think that's one part. And I think the other part is just really including women at all phases of research to make sure that we're asking relevant questions that are important to women and for women.
Great. Well, we're quickly approaching our hour together. So I want to give each speaker an opportunity to share a quick takeaway that you want our audience to come away with. So maybe something that you want to emphasize, or something that you didn't get to mention. So Dr. Carr, let's start with you.
One thing that I didn't get a chance to mention is essentially we are having pregnancies at later stages in life, which is awesome. But at the same time, we are having higher risk of hypertension, diabetes, that are obesity, and other health conditions that are affecting pregnancies and can increase our risk for adverse outcomes like heart attacks, strokes, seizures, and maternal deaths. So when someone's choosing or thinking that they would like to get pregnant, it's really good to either talk to your OBGYN or your family medicine doctor about what potential risk or modifiable risk factors that you have that you can help change if you have the opportunity to do. And like making sure that you are established with a primary care provider when you're young. Don't wait till you're 45 to start having annual exams. That is huge and very important. And so that will help over time reduce health disparities related to pregnancy as well. So making sure that we're like looking at women's health care, not only just stopping or being around pregnancy, but even prior to years prior to conceiving, and then through our menopausal years and beyond. It's important.
Great. Christina?
I would just want women to know when it comes to their mental health that it's okay to prioritize yourself in this area. Just do the things that you need to do. If you saw your child struggling, if you saw your spouse struggling, if you saw your mom, your dad, we are very quick to want to take care of other people and to notice things that worry us in other people. But if we spent half as much time worrying about our kids as we worried about ourselves, I think we would be healthier people, because we wouldn't let our kids go on with the symptoms that sometimes we ourselves are experiencing. We would get our kids help a lot faster than we let ourselves go without care, whether that's mental health care or physical health care. Dr. Carr has such good reminders, even for myself personally, to make sure that I'm getting in with my OBGYN on a regular basis, because I wouldn't let one of my boys miss their pediatrician physical. And so I shouldn't let myself miss it either. And if my boys were sad, I would do something for them to feel better. So if I'm feeling sad, I should do the same. So I would just want women, for maybe for once in their lives, to put themselves on the same priority list as we put everybody else, because we're very, very good at taking care of lots of other people, but sometimes we're not always great at taking care of ourselves.
Thank you. Sarah?
I think that's a really great point that Christina and Dr. Carr both had. On top of that, I would just add that we've brought up a few things from the political atmosphere, local issues that are going on that really are impacting women's health care. And I think it's so important that we understand that it's going to take all of us to make change. Just like it takes all of us to provide great health care to women, we want to make sure that the research is there, that we are doing the right things for women. We want to make sure that employers are supporting what they need to do to get women in the workforce, but also take care of themselves. We want to make sure that women have great mental health care that they need and the physical care that they need as well. And so we have to recognize that there is not one entity or one discipline that's going to be able to do that. It is going to take all of us to be able to work together in a collaborative way.
Great. Nicole?
Yeah, so I will echo everything that the other panelists have said. I will put out there that it is really important for us to think about what we want Iowa to look like for women. And part of that is women being able to go and receive care. But to be able to do that, we need policies that are supportive of Iowa women. And so to really take a moment to think about, when you vote, how do you want to vote in a way to ensure that we have a state that supports women?
Thank you. Well, thank you all for being with us today, sharing insights with us. On that note, I want to turn it back to Stacy, who is going to help us wrap up today's webinar.
Yep. Hi there. We have a few things coming up here. Our July and August Uncovering and Unveiling event. We also have our Innovation Iowa event at the Des Moines Heritage Center coming up on July 10th. So we want to make sure that you are all aware of that. And then also we would love for you to celebrate our Women of Influence event coming up on Thursday, July 31st at a new location this year, the Hilton Des Moines downtown. We will have the networking portion from 4 to 5:15 and our program from 5:15 to 7 p.m. You can register at the code below or on our website. This year's honorees, we have Courtney Clark, Bridget Cravens-Neely, Susanna DeBaca, Dawn Refsell, Sally Dix, Sally Frank, Christina Moffett, Jackie Norris, and our two award winners this year, Federal Home Loan Bank of Des Moines Emerging Women of Influence, Courtney Shaw, and the Iowa State University Ivy College of Business Owner of the Year, Kimberly Baith. So we're excited to celebrate all of those women this July 31st, and we hope you can join us. We'd love to gather more story ideas, and if you have any questions about bringing anything to the attention of our staff, Macy Schofroth, you can reach her at her email there below. And if advertising and sponsorship opportunities, please reach out to Lynn Belknap with her email below there as well. So, Emily?
All right. Well, thank you everyone for attending. Thanks again to our speakers and our sponsor. We hope you all have a great rest of your day.